computer. Okay. The recording has started. Bienvenidas, comadre. It is absolutely my honor to, and privilege really to have, for las comadres to have this experience today, sharing of maternal health and the information that comadre Dr. Lourdes Rodriguez will share with you. I'm sure you got a chance to read her bio, and if not, you will have a chance later. But I'm going to tell you about how I met Comadre Lourdes. And actually, she came to Texas from New York, and I didn't know her in New York. But when she came here, one of the first things she did is join the local network. And you may have joined it beforehand. And then we became friends and we started sharing information. And she was at the University of Texas teaching and working in population science, algo así, department. And she then introduced us to Dr. Renee Salazar, who is at the Dell Medical School. She also was at the Dell Medical School. So we had a comadrazo at the Dell Medical School. And Dr. Rodriguez made that happen. And so we've created this relationship for a long time. And then she switched over to St. David's Foundation as the senior officer for women's programs. And that was her passion. She was home. And so she has created programs and done so many incredible things in this community. Lourdes, I want to thank you for how well you represent and how well you take care of the women in our community and all around you. So without further ado, Dr. Lourdes Rodriguez, who, my friend, and to many of you, she is also a colleague and a friend. And take it away. We are recording. And I hope that you're okay with that. And if not, like I said, put yourself on camera. And for questions, you can just ask the questions. We want you to type them in the chat so that we have a record of it, a quick and easy record, but feel free to ask them. This will be conversational. It's us talking to each other. Comadre, take it away.
Thank you so much. And de verdad, mil gracias for the opportunity to speak on the topic of perinatal health. It makes me very happy to do that. And before we start, I want to encourage you to please put your name and where you're zooming from, because I see that there are some phone numbers. If you can, please, because that way, you know, like we'll get to see who else is in the Zoom room. And if there's comadres that you have not seen in a while, feel free to like private chat them and connect with them, because this is all about, you know, making connections. And so, yeah, so please put your name and where you're zooming from. And I want to, with your permission, just talk a little bit about the foundation, because it will help you understand the context of the work. So St. David's Foundation was created in 1996. And we have a partnership with the St. David's Healthcare, but we're separate and different from St. David's Healthcare. Through that partnership, the foundation reinvests the proceeds from the healthcare system back into the community. And annually, we do that by investing about $80 million roughly in grants, in programs, direct service through our dental program, and other philanthropic activities. The 5-county area that we serve is Bastrop, Caldwell, Hayes, Travis, and Winston counties. And at the end of the presentation, I will share a link to a funding opportunity that is currently open right now for people who work in nonprofit organizations that are serving those 5 counties. And at the foundation, I serve as the steward of the resources in the Healthy Women and Girls area. And while the first thing that I would tell you is that I and the rest of the foundation acknowledge that women are more than their capacity to reproduce. I hear you loud and clear. I believe it so. However, because our maternal health outcomes in Texas, specifically maternal mortality and morbidity, so health conditions that are a result of that pregnancy period are so bad, so poor. If we had to start somewhere in the area of women's health, that was the place where we thought we had to start. So acknowledge that we're more than our wombs, and we had to start somewhere, so we started there. So the way that we do that work is that we want to achieve birth equity. So we want to make sure that everybody has the same chance of having a pregnancy that goes to full term and that is healthy. We want to increase access to family planning and contraceptive care. And we want to work with you, and I'm looking at all of you in the Zoom room, to ensure that we have strong communities that support women and girls. Um, and you know, some of the types of grants that we give in the women's health area include grants for women's health services, um, and projects that come from the wisdom of women of color, because we want to center our work on women of color because they're the ones that are most impacted by poor health outcomes. Um, and and then the third thing that we're trying to do is establish what we're calling a perinatal safe zone. And I will give you more details, and I will define what perinatal safe zone is in a hot second. I promise you, I'm not going to bore you with a lot of numbers, but I will put in the chat links to reports, and there will also be a follow-up email that gives you all of those numbers. But in the interest of not having your eyes roll over to the back of your head, I'm not going to give you a lot of numbers, just a few of them. And to ensure that we're all in the proverbial same page, I'm going to start by giving some definitions to things that I'm going to be talking about, right? And I am going to put the terms in the chat box. I'm not using slides, but I'm going to use the chat box a lot. And so that you can see what the terms that I'm going to define. And they're all in caps, not because I'm screaming at you, but because I want you to be able to see them quickly when we get to, when you look at the chat. So there goes the definitions that I'm going to be talking about. So let me start by defining perinatal health. This term, perinatal, refers to the period pre-pregnancy, during pregnancy, and postpartum, right? And I am defining perinatal health as the health of women before they become pregnant, during their pregnancy, and postpartum, because I believe that to have good maternal health outcomes, you cannot just limit yourself to the 40 weeks of the gestation period, right? Like, you need to think about how healthy are our bodies when we are seeking to get pregnant or before we get pregnant, and postpartum, right? Like that first year postpartum is critical to women's health. And if we only focus on, like, you pop the baby out and you're done, then we're missing a lot of opportunities to improve health outcomes. The second term that I want to define is maternal mortality. And I'm using the definition used by the maternal mortality review committees that the CDC established in states that have really high rates of maternal mortality, Texas being one of them. And these are, they define maternal mortality as deaths during pregnancy, childbirth, and the postpartum period up to a year from the end of pregnancy, and that these are deaths that were somehow connected with all of the changes that go in our bodies during the time of pregnancy. In the last time that, so right now the maternal mortality review committee is looking at what our current rate of maternal mortality is. The last time that they reviewed it in 2018, they estimated that out of every 100,000 births for the state of Texas, 18.5 women died. So let's just round it to 18, right? So 18 women dying out of every 100,000 births. But when you disaggregate the data, when you separate it by different kinds of women, right? For Black women, that number was 37.1. So 37 women die in pregnancy. Black women die in pregnancy as a result of pregnancy. And for white women, that was 14.7. And for Latinas, it's 11.8, which is lower than our white and Black counterparts, but it's still high. Like that, like birthing should not be a life or death situation, right? Like, our bodies were created for birthing. So then what are the conditions that put us at risk for that, right? And we'll talk about that in a second. The third term that I want to define is maternal morbidity, right? So morbidity refers to disease or health conditions, and maternal morbidity is defined as unexpected outcomes, so things that you were not really hoping that would happen, that happen as a result of labor, delivery, and that have short-term and sometimes long-term consequences on women's health, right? And so remember, right? I don't know how many of you have ever been pregnant, but our we go through a lot of stress. Our bodies go through a lot of stress, physical stress. You are pumping larger volumes of blood. Your internal organs get rearranged, and I really hope I'm not scaring any of you who haven't had babies yet. Like, it's a joy, but all of these things happen to your body, right? And that stress, if not if we're not taking care of ourselves, and if we're not living in conditions that allow us to have a healthy pregnancy, can lead to long-term health effects, right? So some of them are related to cardiovascular health, again, because our hearts are working extra hard, and they include things like heart attacks, aneurysm, fluid entering, the amniotic fluid entering the mom's bloodstream, right? So all of that gunk that is floating there, um, 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 erratic heart rhythm, right? So our hearts are, again, are working extra hard. There's other conditions, other health outcomes that are related to organ malfunction. So for example, renal failure, respiratory problems, accumulation of fluid in the lungs. Some other ones are related to the medical procedures that are associated with pregnancy, right? So complications related to anesthesia, sepsis, which is a infection of the blood, you know, in the impact of a hysterectomy, if you have to go through a hysterectomy. And then there's also um, some morbidity issues related to pre-existing conditions, like in the case of sickle cell anemia, right? So we're going to be talking about the factors that impact maternal morbidity and mortality, and those are the first words that I define. And I'm going to put in the chat some resources that I'm also going to email you afterwards. But in case I bore you and you want to go and look at those links while I'm talking. The last definition, I promise, is it's health factors, and I'm paraphrasing from the county health rankings. And health factors are the things that influence how well and how long we live, right? And everything from our education to our environment impacts our health. And health factors is a term that is specifically used, things that we can modify, right? Things that we can modify to improve the length and quality of our life. So I am not going to talk about race and ethnicity, because race and ethnicity is not a modifiable factor. I was born Puerto Rican. I will always be Puerto Rican. Like, nothing about my Puerto Ricanness should put me at risk of poorer health outcomes, right? So that's not what I'm talking about. I'm talking about health factors that can be modified. And apologies for the loud chicken. There are, you've heard of the term that no person is an island, right? And if you understand, and if you believe that, you understand that individuals we are nested, right? Like the bowls that are different sizes that you put inside each other to save room in your counter, right? So individuals are part of families. Those families are part of communities. Those communities exist within a city or a municipality that is part of a state, in a country, in this planet that we call Earth, right? So we are nested. And when you think about those factors that can be modified, you can modify some factors at the individual level, right? At the level of the networks or the communities, right? So when I speak, I'm not only talking about things that are the responsibility of the mama. I'm going to talk about things that other folks around the mama can contribute to. So I promise you there's going to be time for conversation. I'm going to now briefly talk about the factors that contribute to everyone's health, men, women, old, young, pregnant, non-pregnant. And then I'm going to talk about how those factors um, can impact the pregnancy period or the perinatal period. And I'm going to start by the ones that have least influence, and I'm going to end with the ones that have the most influence. So our physical environment contributes about 10% of our health. And that is whether we have access to good, clean air and good quality water, the housing conditions in which we live, right? The quality of the housing stock in which we live, and the transit systems that help us move from one place to another and access services. And the second category, and I was surprised when I was a student and I learned this, is clinical care. Clinical care contributes only 20% to 20% of our health. Okay, so access to services, healthcare services, clinical services, and the quality of those services only contributes to 20% of our health. That means that the other 80% are things that are not under the purview of the healthcare system. And we can go have coffee and talk in more detail about that, because I think that it is mind-blowing that we spend so much money on healthcare in this country, and we have very little to show for in terms of the health of our population. The third health factor that impacts our health are our health behaviors, right? So the things that we do, the things that we put in our body, the things that the decisions that we make contributes towards about 30% of our health. And that includes things like whether you choose to smoke or not, whether you choose to eat a healthy diet and move around and exercise, whether you choose to use alcohol and other drugs, or the kind of sexual activity that you engage in. And the last, but certainly not least, set of factors that impact our health are social and economic factors. And they contribute a whopping 40% to our health. And these include our education, right? So our level of education means that our employment is likely to be allow us to earn more money, and if we earn more money, we're likely to have access to things that money can buy, right? Money cannot buy happiness, but it can certainly like buy you a really good healthy food, and like allow you the opportunity to take the time out of your busy day to go and exercise, for example. um, the the family and social support that we have, right? So the networks that we're connected to, and the community safety, right? So whether you live in a neighborhood where you can freely walk and enjoy, life with your neighbors, or whether it is a community in which you feel unsafe and you would not be caught dead after the sun goes down, right? All of those factors contribute about 40% to our health. So for the rest of the presentation, I'm gonna go through that list, right? And I wanna tell you a little bit about the link between those things and maternal health. So if you think about poor air quality can trigger things like asthma attacks or cause other pulmonary problems. And in a pregnant body that's already working overtime, right, that can have damage on and our internal organs are moving around, so there's pressure against your lungs. So poor air quality means that you're not only not receiving what you need, but like your body is not being able to take advantage of the little air that you're breathing, right? And to filter it in the way that it has to, because again, our bodies are working overtime. In Texas, wildfires are a bigger deal than you can imagine, right? And so areas with a high incidence of wildfires have poorer air quality, which means that the people who live there, and especially pregnant women, are going to be impacted more. In terms of water quality, in many communities in Texas, they rely on water service from small, poorly regulated, privately owned water companies. Okay, and so the quality of the water is not always monitored, and it's hit or miss whether you get good quality water in those areas. And in other areas, that rely on septic tanks because there's no a public sewage infrastructure, you're going to have a chance of your good water getting mixed with the septic tank water, and without you knowing it, you are going to be ingesting pathogens that can make you sick and gross, right? um, in terms of housing in transit, like I alluded to earlier, unhealthy housing conditions like housing that has mold, or where there's poor pest management control, or when it's controlled, if you're using hazardous chemicals, all of that can have an impact on mama and on the baby in utero. And in places where there's lack of public transportation options, for example, and you don't own a vehicle, getting access to resources um, is difficult. But the opposite is also true, right? When you have to rely on like everybody owning a car, you have more air emissions, right? So then the quality of your air is poor. Next to the next factor that we talked about, clinical care, access to care in this moment of a woman's life is critical, right? And in Texas, if you think about it, about half of all births, I'm going to repeat that, about half of all births are covered by Medicaid for mothers. And currently, the coverage through Medicaid for mothers ends 60 days after delivery of the baby. Okay. And remember that the definition for maternal death includes things that happen within that first year. So you can imagine that if you are uninsured after those 60 days, the likelihood that you're not going to have access to the care that you need is really high. And the data shows that the majority of maternal death and morbidity complications happen after those 60 days, right? I will tell you that currently, um, extending Medicaid for mothers after the 60 period is something that we did as part of the changes in policies during the pandemic. So we now have a natural experiment where we can see the impact of extending Medicaid for mothers for a whole year. And right now, in this legislative session in Texas, Bill HB 133 is proposing to extend Medicaid. It already passed the House, and it's waiting to get a hearing in the Senate. So if the spirit moves you, and this is Lourdes, not like the Employees and Davis Foundation, if the spirit moves you, call your senator and tell them how you feel about the health of women and why we should consider expanding Medicaid for mothers to a year. The second of those factors within clinical care is the quality of care. And if there's one thing that I want you to leave with here is that quality of care is not only about having access to the latest technology or the best available treatments, it's also about ensuring that there is no room for implicit bias creeping in the patient provider relationship, right? When there's implicit bias, women don't get what they need, women are not heard, because the moment that you walk in, for example, with your Medicaid card as a mom, there's all sorts of assumptions about who you are, the quality of your human being. If you are a poor person, you could be working in a place, like 40, 50 hours a week, and your employer doesn't offer insurance. So you have Medicaid, right? But there's all of these assumptions about who you are because of the coverage that you have that can color the way that people treat you, right? So quality of access of care is something that, that can have a negative impact, and that we should be thinking about what we can do about it. In terms of health behaviors, tobacco use is something that we can address through things like smoking cessation programs. Diet and exercise is something that we can address through not only health education, but also ensuring that there's access to affordable, delicious, nutritious food, um, and that we have the purchasing power to acquire that delicious, nutritious food, right? And that we have spaces, safe spaces where we can be physically active, right? So I know that Comadre Nora loves to go walking because I see her walking in front of my house daily, and she waves and we wave. Right. So access to safe places where you can be physically active is also important to be able to allow you to make that choice. Right. Um, the alcohol and drug use, being able to have health education, but also recovery programs, right? And not only recovery programs, gender informed recovery programs, because being an alcoholic is viewed poorly if you're a man, but it's even worse if you're a woman, right? And if you have children and you are going through an opioid addiction, for example, having services for yourself that do not include space for you to have your children means that you're likely not going to go through the entire program and be able to take care of yourself. So having access to those things is really important. and and also the sexual activity in which you partake, it's something that we can address through health education, but also access to barrier methods, right? So that if you're making choices that may not be the best for you, at least that your health is going to be taken care of because you're using barrier methods. um, and then the last part, and in this part I am hoping that we can have a little bit more of like less of me talking and more of you participating, is these social and economic factors, right? Because whether somebody completes or not their education is not an individual feat. It takes a community for people to get through their educational journey successfully, right? Employment is something that we all need, but it's critical for people that are pregnant, right? Because they can get their insurance through good employment. And employment is something that you sometimes get because not of what you know, but because of who you know. So being able to network and share information through networks like Las Comadres is one way in which we can support healthy pregnancies. Income, right? Like being able to learn from each other how to negotiate our contracts or how to advocate for fair wages for everyone, right? Like that's something that we can all speak to. um, the family and social support. Like I cannot speak, like more highly than Las Comadres and the kind of support that we provide to each other. I hosted a comadrazo here before the pandemic, and I cannot wait till we can have the next one, because that connection, that the connection to other comadres, it provides the network that you can rely on when things happen that that can get in the way of you, in the case that you were pregnant, that you could have a successful pregnancy, right? So imagine that. I'll tell you a personal story. When I was pregnant with baby number 3 with Elisa, um, babies number 1 and number 2 were being taken care of by my husband at home. But when I was ready to push that baby out, we needed a comadre. So we called Comadre Elizabeth, our neighbor and my dear friend. And she was the one who at 3:45 in the morning got out of bed, came over and took care of babies number 1 and number 2. Right? Like imagine if Raj had not been able to be with me, that would have been heartbreaking, right? So that family and social support is critical in during the perinatal period. And community safety, right? Like we all, our eyes on the street, on the sidewalk, in our neighborhoods provides and creates safe communities, right? So community safety is not only about ensuring that we have a cop doing their beat in our neighborhood. It's about ensuring that we all look out for each other, right? And with that, I want to take the rest of this time to hear your stories about either your pregnancy or a friend's pregnancy or the pregnancy that you want to have or the kind of comadre that you want to be to pregnant people. So that's my spiel, and I cannot wait to hear from y'all. You can put questions on the chat or you can just unmute yourself.
Thank you, Lourdes. That was very, very enlightening. You opened my mind to a lot of ways that I had not thought about pregnancy and the environment, the ecosystem of health in a pregnancy. Comadres, please ask your question.
And if there's something that I did not explain clearly, I'm happy to go back and re-explain it. I was talking about you. This is Elisa. This is baby number 3.
Hello.
Hi, Elisa.
And look how big and beautiful she is now.
Almost
I know. You are almost as tall as me.
Hi.
Hi, sweetie.
Hi.
I will comment. I thought very interesting. Are when you separate these into the four groupings, are these social determinants of health? Is that
So some of them are the fourth category, right? The
Okay.
category of social and economic factors. Those are the social determinants of health, right?
Okay, that grouping.
Yeah.
Mhm.
And I mean, to some extent, the environment is as well, right? So being able to have, good air quality and anything that is not clinical,
Mhm.
right? Anything that is not clinical care would fall within those social determinants of health.
Got it. I was very surprised by the percentages in those groups. Yes, very surprised by that. And I'm wondering how they determined that. Like what?
Oh, if you want to get nerdy with me,
I do. I would
paper.
You don't want to get nerdy with her.
I do want to know. Because how did they assess that based on outcomes and all that? I would be very curious to know.
It's called a meta-analysis, right? So you take the research that people have done before you that determine the impact of a specific intervention on your health, and then you start looking at the percentages across those interventions, and then again, if you want to get nerdy.
Yeah, I would love to see it if it's published. I would love to see the journal article or whatever.
I'm gonna make a note to myself here.
Thank you. And it seemed to me like this was not just about pregnancy. It seems like it's about just health in general.
Oh, yeah. Right? So this group of researchers funded by the Robert Wood Johnson Foundation create annually, or maybe it's every other year, what's called county health rankings. So you can look up like where Travis County lays in comparison with Williamson and Baxter, right? So they use this as a way to help communities decide where they're going to put their emphasis in terms of work to improve health at the population level, right? I use the framework to explain the factors that not only impact everybody's health, but how those affect you differently because of the pregnancy context, right?
I see.
So I needed to choose a framework, and I like that one because I think it's very
cool. Great. Yeah, I'm interested for a lot of reasons because I do a lot of work in the, Latina research space, as you know. Right now, we're working on a project for Telemundo where we're writing the next part of the Mujeres publications and papers. And the big question that everybody has is, now with COVID, what is the pandemic effect?
Yeah.
To what extent? And are these things going to be lasting, and for how long? That what everybody kind of wants to know, what will the recovery look like, and where are we getting stuck? And I think so much of this is pertinent. So it was just trying to sort through all of the effects, which so many of these things had to have been affected.
Yeah. And if you think about the economic impact of the pandemic, most of the jobs that were lost that are not coming back were lost by women. So this is a she-demic, right? Like,
ooh, yes.
And so the 19 has done a really good job at covering the pandemic with a gender lens.
The what lens?
The 19.
The 19
is a
newspaper.
It's like an online newspaper. I turned this light on because I'm outdoors in the casita and the sun is setting and I am about to lose lighting. So it's not that I'm being vain and trying to get the right.
That's great. No, thank you.
I'll send you information on the 19th. I subscribe to that.
Absolutely.
It's actually a Latina is one of the founders of the 19th.
Right.
Be happy to introduce her work.
Oh, perfect. Thank you.
So Lourdes, I had a question about the Latinas being the lowest, 11%. Okay. So what's that tied to? Do we eat better? Did we, what, not just eat?
Yeah.
What do you attribute that to?
So I have a colleague who studies what is called the Latino paradox or the Hispanic paradox, that not only in the pregnancy, right, but across other indicators, Latinos tend to have better health outcomes than other groups. And one of the things that she says is that for some folks is the being first generation in the country means that you have better all sorts of habits because you have not been acculturated to the American way of life, right? Or the standard American diet. And the standard American diet acronym is SAD because it is a sad diet, right? If you look at like what most Americans eat, right? So that's Dr. Abraido Lanza, Ana Abraido Lanza, and she talks about the Latino paradox. And I can also send you more information about that. So that's one reason. I personally think that the familial networks, that support that we provide each other, is also a contributor, right? Because we rally around each other, and we and that is more likely to happen among Latinos than in other groups. And then, you know, the spacing of babies, right? And when you have babies also contributes, right? We tend to have our babies younger. Like, I'm an anomaly. I started having babies in my 30s. I'm an anomaly. But Latinas tend to have babies younger. And when you're younger, you're more likely to have better outcomes because, one, your body has not experienced the weathering of like accumulated stress. And that's one reason. Second, because like your body is just ready, right? Like, it's ready, and you are doing what you are supposed to be doing, right? Like we're not only made to procreate, but our bodies are made to procreate. Otherwise, we would not have these beautiful breasts, right? And we wouldn't have this beautiful womb, right?
And the men like them.
These thighs, right? Like, we wouldn't have these hips, right? So our bodies, our biology is designed for that. So an early pregnancy, like, it's something that your body biologically, like, we are prepared for those things. I will tell you that our society has created expectations that are different from what our biology is, right? So the expectation that, and please, like, don't misquote me, all right? Like, when my mom was being raised, the expectation was that she would be married by 14 or 15, and that she would run the farm with her husband, and that she will have lots of babies, right? We have built society expectations that say that you should not have babies until you have completed your education and you're well established in the world. That makes a lot of sense in this social context, right? But biologically, the moment that, so for baby number 2 and 3, the moment that I turned 35, like, I started to have all of these tests because I was a high risk pregnancy at 35. So does that answer your question, Nora? Like, there's a bunch of factors. Other questions, comments, or if you want to tell your pregnancy story, those are welcome as well.
Hi, this is Rosa.
Hi, Rosa. And then after you, Susana. Go ahead,
Okay.
Rosa.
I should have raised my hand. Sorry about that.
No, it's all good.
So I only had one pregnancy. My first pregnancy, I was pregnant at 24, married, and all of that. But he was a healthy, he's still a healthy baby. But at 3 years old, he was diagnosed with asthma. I mean, for asthma, I know there's different factors, but I mean, and I took care of my body and all of that. Does that have anything to do with like how kids develop certain things?
So Rosa, the first thing I'm going to tell you is that I absolve you of any guilt you may carry in your beautiful heart that you gave your kid asthma or that you passed it along through your genetics. All right. So please like take that guilt out of your heart because it's not you. All right. So our genetic code, now I'm going to talk about epigenetics. So our genetic code has all sorts of switches that can be turned on and off. So I may have a gene that predisposes me for asthma, and it may never be turned on, and I will never have asthma, or I will never experience it early on in my life, and something happens through my life trajectory that turns that gene on, and all of a sudden, as an adult, I develop asthma, right? So what I imagine and what you can talk to your doctor about is that at some point, the accumulation of triggers or exposures turn that gene for asthma on. And so no guilt, and epigenetics is a real thing.
Thank you.
Okay.
No guilt.
Right.
Thank you.
Susana.
Okay, hi. So I posted one question in the chat, but then while you
Oh,
were
I didn't
talking,
see it.
oh no, but then while you were talking, I had another question.
Okay, so read the one that you posted and then ask your other one.
Okay, so the one that I posted was, what would you say is the role of the provider when they're like giving care in the prenatal and the postpartum period? Because I've heard that like some providers are like, we don't get paid enough to like do all these extra
I know.
things.
And that's the problem that we have with our current healthcare system. Like if you go to the doctor's office for one issue and you start talking about other issues, the likelihood that they'll tell you is like make another appointment is because they don't get paid enough to talk to you like you are a whole person. They talk to you like by problems, not as a whole person, right? So that is a problem of the way that we have designed payment structures in our healthcare system. And that's a whole nother conversation. We could go have coffee, Susana. The role of the provider depends on who the provider is, right? So if you think about maternal health as having a rainbow of different kinds of providers play a different role. So your OBGYN may only think about the prenatal care and the delivery period. If you have a doula would think about not only like monitoring your temperature and your blood pressure and your hormones, but also talking to you about what you're eating and like and describing to you what can you expect when you go into delivery. A birth companion is another kind of allied health worker, and that person will be with you in the delivery room if you don't have a partner, or they will be with you and your partner so that your partner can concentrate on you, and then your birthing companion can talk to the clinical team and advocate for you so that you can get what you need. A lactation consultant is going to ensure that latching and breastfeeding initiates well. It is it's a thing of beauty to be able to breastfeed your kids. And it hurts like a beep, beep, beep when you first start letting milk. But if you have a lactation consultant, that person can help you with managing the discomfort and ensuring that you don't quit too early because of all of the complications that can happen, engorgement and all of those things, right? A nurse midwife, again, can offer the same kind of prenatal care than an OBGYN, but they are more likely to see you as a whole person than somebody who only gonna monitor. My prenatal care was like for at least the first 2 babies, I felt like it could have been better. Like I was just going in and out of the doctor's office and being monitored. And I had to seek other, like a Bradley method teacher to help me understand what I needed to do to get ready to push that baby. So it depends on the kind of provider. Does that answer your question, Susana?
Yeah.
Right.
It all sounds very like piecemeal, like you said, like very.
It is, sadly. And one of the things that I am trying to do at the foundation is think about how do we integrate those folks a little bit better, right? One. Second, the highest paying professionals that are doing things that are not necessarily adding value to your pregnancy. So I want to liberate some of those dollars from the healthcare system so that we can pay for the providers that have the time to spend more time with you, because their pay rate is going to be a little bit lower. It should be living wage, but it's not going to be the same cost as an OBGYN. Yeah, it is
Okay.
piecemeal. You're absolutely right.
Maybe that's a project for us. Let's build that and help people understand the questions. Lourdes, I want to tell you, you wanted to leave or you needed to.
I
leave.
know, but I want to make sure I answer
Okay.
Susana's second question. So Susana, you have the last word.
Oh, well, I guess going back to like how Latinos are healthier, if you're like first generation and all of that, that still means that we still need like this really good quality care.
Yeah, absolutely.
Regardless, right?
11 is
I
still
just
too
wanted
high.
to point that out, like the obvious.
Anything over 0 is too high. Like we should not tolerate maternity being a life or death situation. So thank you. I completely agree with you. And mujeres, I have a 7:30 commitment that I need to go to. I need to pack my office, change my office chancletas, and drive over to my 7:30 commitment. It's been such a pleasure spending time with you this evening.
Did you want to talk about the grant?
Oh yes. So, oh my gosh, thank you. So so what we've been talking about today, for me, is part of creating what we're calling a perinatal safe zone. I am going to put the information for the perinatal safe zone in the link, and I will also follow up with that in an email. And basically, it's an invitation not only for you to apply for support from St. Louis Foundation if you're part of a nonprofit, but also to think about how, like, for you to think about what is your contribution as an individual with the pregnant, women in your life, whether they're family or they are people that you bump into on the street or people that you serve in your work, like, and right. So as an individual, what can you do to make every pregnancy as healthy as it can be? But also, if you are in a position of making decisions, if you're in a position of power, if you're in a position to inform policies or how things are done in you have influence at work, or as part of other roles that you play at your church or as part of an organization like Las Comadres where you're a member. Think about what can you do to contribute to this. I call it a movement, but let's call it a community of practice, because sometimes people get scared when they hear the word movement, right? How can we create a community of practice where everybody feels like they should give a rat's butt about every pregnant person that they encounter? So read the request for proposals. If you are interested in submitting a project, we have an information session on March 11 at 11 o'clock. And I will also send in the email information about how to register for the info session. That beep beep is my battery dying. And yeah, like I hope that as Las Comadres, this is just the beginning of a conversation about how we, right, can contribute to better maternal health in Texas and wherever you may be. Christy, you in New York, right? So, and Rosa, you in Boston, right? I think that's where
Yes.
you are.
Yes, yes.
So we're
And
creating a movement.
Viviana is in Nashville.
Oh, awesome. So thank you so much. And invite me again and we could keep doing this.
Thank you very much.
Very wonderful. Thank you so much, Lourdes. Look forward to working with you.
Okay, a la orden siempre. Ciao.
Thank you. Bye.
Thank you.